So I think we can start. No? So we are starting with nephrotic syndrome. So next slide. So the objective is to be able to define nephrotic syndrome and to understand the pathogenesis, know the types, and be able to make a diagnosis and institute management. Next slide. So this is just the outline for the presentation. Next slide. Next slide. Yeah, so by way of introduction, nephrotic syndrome is not a diagnosis per se, a single diagnosis, right? But it's actually a feature of number of kidney disease. So most or a lot of kidney disease present as nephrotic syndrome. So it's not a single disease entity. And it's the commonest renal disease that is seen in children. It's a syndrome. When we say syndrome, that means a collection of signs and symptoms, several or different signs and symptoms. And the syndrome is characterized by heavy proteinuria. When we say heavy proteinuria, it's protein that is more than 50 milligram per kg per day, or more than 40 milligram per meter square per hour. Then there's hypoalbuminemia, that is albumin of less than 2.5 milligram per dl. Then hyperlipidemia and massive generalized edema. So this is what makes the syndrome of nephrotic syndrome. Next slide. So actually several figures. The peak incidence of nephrotic syndrome in Nigeria is between 5 to 8 years of age, as against what we see in advanced countries. Developed countries, usually the peak incidence is usually around 2 to 3 years of age. Hello. We have to mute too. There are a lot of people that have not, Musaiba, Rabia, they have to. Sorry, my screen is having a little problem. So sorry for the little delay. It's due to technical problem. So like I was talking, we're talking about the epidemiology of nephrotic syndrome. We said the prevalence ranges between 2 to 4 new cases per 100,000 population. Like we talked about earlier, in our population, the peak incidence is 5 to 8 years, and which is differs from what we see in advanced countries where they have peak incidence of 2 to 3 years of age. And there is a slight male preponderance in our environment. Next slide. Next slide. So the commonest type of, no, previous slide, previous. Yeah, so the commonest type of nephrotic syndrome, next slide, is the minimal change disease. That is the type that is mostly seen in Caucasians. But in our own environment, the commonest type we see is the focal segmental glomerulosclerosis or the membranous nephropathy. Please let's get that statement that in our environment, the focal segmental and the membranous nephropathy are the commonest types we see against the Caucasians, where the commonest type is the minimal change disease. And that is why it tends to present earlier, from 2 to 3 years. But the focal segmental glomerulosclerosis presents usually in older children. So that is why the peak incidence in our environment is 5 to 8 years of age. Next slide. Next slide. So the focal segmental is the commonest cause of chronic kidney disease in children worldwide, and is usually steroid resistant. And mostly about 25 to 30% will progress to end stage or chronic renal failure. So it's actually a very significant common problem, common cause of end stage renal disease in children, especially in our environment. And another challenge it poses is that even in the newly transplanted kidneys, it can affect the transplanted kidneys, leading to loss of that transplanted kidneys. So focal segmental glomerulosclerosis is one of the commonest cause of end-stage renal disease in children. Next slide. Yeah. So the pathogenesis, the hypoproteinemia results from massive loss of protein in the urine, because the basic pathology is loss of protein in the urine. And this results from the loss of the normal negatively charged glomerular name, because the glomerulus normally is negatively charged, right? So when there is loss of this negative charge, and as a result, the protein, is positively charged. So when there is loss of this negative charge, there will be attraction, and that will lead to loss of protein in the urine. So because of that loss of protein in the urine, there will be hypoproteinemia. And because of hypoproteinemia, what happens is there will be reduced plasma oncotic pressure. And that reduction in plasma oncotic pressure will cause the edema. Is that clear? Please, if you have questions, you can ask. Next slide. Yeah. So then there is increased permeability of the glomerulus, and the main cause is not known, but some of the factors is due to immune dysfunction. Immune dysfunction will cause increased permeability of the glomerulus to these proteins, and that will result in loss of protein in the urine. Next slide. Next slide. Next slide. So the edema, we've talked about the causes of edema earlier. We said the major cause is due to hypoalbuminemia, which will cause reduced plasma oncotic pressure, and that will lead to edema. Then other causes include increased ADH secretion. Then there is activation of the renin angiotensin system. Then there is stimulation of the sympathetic nervous system and suppression of the atrial natriuretic peptide. But the major cause of edema is the hypoalbuminemia and low plasma oncotic pressure. Next slide. Next slide. Just skip this. Yeah, the hyperlipidemia results from a It's an increased synthesis of albumin as a result of increased production of lipoprotein. So to compensate for the hypoalbuminemia, there is increased production of lipid, and this increased production of lipid will cause hyperlipidemia. Like we all know, the proteins like albumin, usually it is produced in relation to the lipoproteins, because the kidneys produces both the proteins and the lipids. So when there is reduction in albumin, the system will try to compensate, and as such, there will be increased production of lipids, and also there will be reduction in catabolism of lipids, and that will explain the hyperlipidemia. Next slide. Next slide. Yes. Yeah, sorry. I have a little network challenge. So nephrotic syndrome can be classified into two. We have the primary and the secondary nephrotic syndrome. Next slide. So we have the congenital nephrotic syndrome. The congenital nephrotic syndrome is actually a heterogeneous collection of some diseases that are intrinsic to the kidneys. And it is also called the Finnish type nephrotic syndrome because it's actually very common in Finland, right? So that is why it's called the Finnish type nephrotic syndrome. It is actually rare. Yeah, sorry. It is actually very rare in our environment, and it is inherited as autosomal recessive, and it's mostly seen in low birth weight children. And usually does not respond to steroids. But what is peculiar about this is that it can resolve without treatment. So anytime you see a baby with edema, there's a possibility that it may be a congenital nephrotic syndrome, even though, like I said, it's not common in our environment. I'm not sure I've ever seen a child with congenital nephrotic syndrome. Next slide. It's actually caused by mutation in the nephrin gene. Then usually is also associated with elevated alpha fetoprotein. So other causes of elevated alpha fetoprotein include Down syndrome and other trisomies. So this is also a cause of elevated alpha fetoprotein. The causes of secondary nephrotic syndrome include syphilis, toxoplasmosis, cytomegalovirus, and renal vein thrombosis. Next slide. Next slide. Then the primary nephrotic syndrome, we have basically 5 types. We have the minimal change in nephrotic syndrome, the focal segmental glomerulosclerosis, the membranous nephropathy, then the membranoproliferative and the proliferative glomerulonephritis. The proliferative is also divided into the diffuse, the focal proliferative, the mesangial, and all these are pathologic classification. Next slide. Then the secondary is actually post-infectious. So we have the protozoal. So it can be caused by protozoa, commonly malaria. So malaria is the common cause of nephrotic syndrome. We have Plasmodium falciparum, which is relatively rare as compared to other forms of causes of nephrotic syndrome. Then we have parasites such as schistosomiasis, so Schistosoma mansoni, Schistosoma hematobium. Then the viral infections such as hepatitis B virus, cytomegalovirus, then bacterial infections such as group A beta hemolytic strep, and other multisystemic conditions such as SLE and Henoch scoleum purpura. Next slide. Then other causes include conditions such as bee sting, neoplastic conditions such as leukemia, drugs like iron tablets, penicillamine, and gold. All these can cause secondary nephrotic syndrome. Next slide. Next slide. Then sickle cell disease can also cause secondary nephrotic syndrome, and other metabolic conditions like diabetes and hypothyroidism can also cause nephrotic syndrome. Next slide. So the clinical features, like we mentioned earlier, the primary presentation of nephrotic syndrome is edema. So, and the initial edema starts from the face, especially the periorbital edema, and it regresses as the day goes by. So the history is actually classical. A child presenting with edema that is worst on waking up in the morning. Then as the day goes by, the edema tends to subside. Then subsequently, it progresses to generalized body swelling, now presenting with abdominal swelling, and it may present with features of infection, right? And there may be hypertension in complicated nephrotic syndrome. Usually, they may present with the reduction in urine output, pleural effusion, and pulmonary edema, which is relatively rare. Next slide. Diagnosis is based on the history. When you get a classical presentation of massive edema, is actually suggestive of nephrotic syndrome. Then you do your urinalysis. Usually it will show proteinuria of 3 pluses and above. Then you do your 24-hour urinary protein, which will show protein of more than 40 milligram per meter square per hour. Then you do serum protein. Albumin is usually less than 2.5 gram per dl. The lipid, total cholesterol will be high, LDL will be high, and HDL is usually low. Next slide. Then you can do your urine microscopy, which will show RBC cast and WBC cast, and do urine MCS. If there is schistosomiasis, you see the ova of the schistosomiasis. Then renal biopsy is important in those that have complicated nephrotic syndrome. So a common question is indications for renal biopsy in patients with nephrotic syndrome. So we'll discuss it after the presentation. And there's need for you to do serum chemistry, including electrolytes, urea, and creatinine, which may show hyponatremia due to dilution. Then it may show reduction in serum calcium. Then there may be features of acute kidney injury. Next slide. Then you also screen for hepatitis B, hepatitis C, and HIV infection, because we said it's also a cause of nephrotic syndrome. Then you check complement assays. Usually there is reduction in C3 and C4 in patients with nephrotic syndrome. Next slide. Then kidney biopsy is usually not indicated except if there is atypical nephrotic syndrome. So atypical nephrotic syndrome is nephrotic syndrome presenting in children less than 1 year or children more than 8 years of age. So any child that has nephrotic syndrome with hypertension, or has hematuria, or has steroid-resistant nephrotic syndrome. So all these are indications for renal biopsy. Is that clear? Any question so far? Questions?
Sorry, I have a question regarding the previous slide. Sorry, 2 slides ago. You said for the serum chemistry, apart from the hyponatremia, is there hypo or hyperkalemia?
No. You find hyperkalemia only if
Okay,
the child has AKI.
okay,
But for non-nephrotic syndrome, you're not expecting to find hyperkalemia. But for hyponatremia, in normal nephrotic syndrome, you can find hyponatremia because of dilution. Because the child is
okay.
hypertensive, so there will be what? There will be dilution of the sodium, so it will present as hyponatremia, even though the total sodium is normal. Is that clear?
Yes, sir. Thank you.
So, so any other question? Can we proceed? Are we clear on indications for for kidney biopsy?
Yes, sir. Yeah, thank you.
Yeah. So next slide. So the mainstay of treatment is corticosteroids, and we all know the complications of steroids. It can lead to reduced immunity. So you have to exclude active infection before you start steroid. And the phases of therapy, the steroid mainly used is prednisolone. And the phases, we have the induction phase, the maintenance phase. The induction phase, you start at 60 milligram per meter square per day or 2 milligram per kg per day for 4 to 6 weeks. Then you taper it off to 1.5 milligram per kg or 40 milligram per meter square per day on alternate days. Right? Next slide. Then you can give diuretics. You can give furosemide for those that have massive edema. Then some of them you have to give albumin because we said the major pathology or pathophysiology is hypoalbuminemia. So you have to give albumin in those that have severe hypoalbuminemia. Next slide. Next slide. Yeah, so but you have to be careful in next slide. Next slide. Next slide. Yeah. So so sometimes you may have to give antihypertensives, and usually the antibiotics of choice is ACE inhibitors, such as captopril, lisinopril. And we all know the advantage of ACE inhibitors is they also reduce proteinuria. So, and because the basic pathophysiology is proteinuria, so that is why ACE inhibitors like captopril, lisinopril, and enalapril, they are the first antihypertensives of choice because of that property of reducing proteinuria. And you can also use calcium channel blockers and beta blockers. Next slide. So it's important to get this definition. Urinary remission, when there is absence of protein in the urine. A relapse, when there is now presence of protein in the urine after a negative proteinuria. Next slide. Then we have steroid sensitive, is those that have negative protein after 4 weeks of commencing steroids. Then we have the frequent relapsers, those that have more than 2 relapses within 6 months of commencing steroids. Next slide. So other agents you can use alkylating agents such as cyclophosphamide, you can use levamisole, you can use zinc, but commonly the second line we use after steroids is cyclophosphamide. So please just get the treatment of nephrotic syndrome. The first line is steroid, which is prednisone. Second line is cyclophosphamide. Then you can also use levumasole. You can also use other agents, but the first line is steroids. Second line cyclophosphamide. Next slide. And other supportive management include low salt diet, then advise moderate activity, then daily weighing for the child, and also consider psychological issues. Because one of the complications if nephrotic syndrome is depression. So you have to manage that depression because that is a significant problem. Next slide. Vaccination, you give your normal vaccination because some of these proteins they are using, we all know all immunoglobulins are what? Are proteins. So the child that is losing so much protein is at risk of infection. So it's important to give them adequate vaccination to prevent infection. But it's also important to note that those on steroids, you have to avoid live attenuated vaccines because it can be a problem in them. Next slide. So complications of nephrotic syndrome, the most important is infection. Because like we said earlier, those proteins the child is losing, they are actually what? They are actually proteins. Immunoglobulins are proteins. So the child that is losing so much protein is at risk of infection. Then the child is also at risk of stroke. So they are at risk of hypercoagulable state. They are at risk of malnutrition. They are at risk of renal failure, at risk of pulmonary edema, hypocalcemia, and hyperlipidemia with ischemic stroke, ischemic heart disease. So these are the complications of nephrotic syndrome. And please, we should note these complications. Next slide. Next slide. We've talked about this. Next slide. So the prognosis depends on the age. So have those that are between 1 year to 8 years of age, they have a good prognosis. Those that are less than 1 year and more than 8 years, they have bad prognosis. Then histologic type, those that have minimal change disease have a very good prognosis. Then those that have focal segmental glomerulosclerosis have a bad prognosis. Then those that have steroid responsiveness, they have a good prognosis. Then those that have resistant steroid resistance have a bad prognosis. Then those that have presence of hypertension and hematuria, they also have a bad prognosis. Next slide. So questions. Let's ask questions, please. Questions. Yeah, sorry for the little, I don't know what happened. The thing locked me out and I could not join back. So we'll take questions from the last presentation first before we proceed. Sorry for the issue. I had to keep calling for me to be added back because I could not get back to the meeting. I don't know what happened. Maybe one of the co-hosts decided to take me out. So questions from the last presentation. Please let's unmute and talk. Questions? Questions? Questions?
Afternoon, sir.
I don't have any questions, sir.
Go ahead. Ask your
no,
question.
sir, I said I don't have any
Said what?
question. I don't have any question. That's what I said. I don't have any questions. I'm good with the explanations you gave.
Hello? Sorry, ask your question.
No, sir, I said that I didn't have any questions. I'm okay with the explanations you gave, boss.
But I want questions now. So can we proceed? Can we proceed?
Yes, sir.
Yeah. We are going to discuss congenital heart disease. And it's a very broad topic, right? So we are just going to take an overview of the problem, right? So we have to understand the difference between fetal circulation and adult circulation. So in fetal circulation, the placenta is what is used for blood exchange. So the systemic resistance is very, very low in fetal circulation. Then the pulmonary resistance is very high because the lungs do not take part in gaseous exchange. But immediately after birth, there's a reversal of this. So the systemic resistance becomes very high and the pulmonary resistance becomes very low. So that is the basic difference between fetal circulation and the pulmonary circulation. Next slide. Next slide. Yeah, so this is just what we are talking about. Fetal circulation. You can see the fetal circulation is a relatively hypoxic state. So the fetus gets a mixed blood. So based on any picture I show you, anytime you see blue, it means it's purely deoxygenated. Anytime you see red, it means it is purely oxygenated. And when you see purple, I hope it is purple. When you see purple, it means it is a mixed blood. So as you can see from the fetal circulation, what the fetus gets is relatively a mixed blood. So the fetus gets a mixed oxygenated and deoxygenated blood. But we can see from 72 hours of this is because of shunting through the foramen ovale and the patent ductus arteriosus. So because of the shunting from the patent ductus arteriosus, the blood becomes mixed between oxygenated and deoxygenated. So but from 72 hours of life, it becomes a normal. So there is normal deoxygenated blood going to the lungs for oxygenation and oxygenated blood going to the circulation. Is that clear? Next slide. So after delivery, there is removal of the placenta, and with the removal of the placenta, the circulation changes. Now blood flows into the lungs and the ductus closes. So the blood that is supposed to mix, there is no mixture. And like I said earlier, now the system gets purely oxygenated and the lungs get purely deoxygenated. Next slide. So what's the epidemiology of congenital heart disease? Is seen in about 8 per 1,000 live births. However, the incidence increases in stillborn, seen in about 3 to 4 per 100. Then for premature infants, is seen in 2 per 100. Then for abortuses, is very high, 10 to 25 per 100. And most of these congenital heart defects are relatively well tolerated in the fetal life. The etiology of the causes is unknown, but there are some factors that are associated with increased risk of congenital heart disease. Some of these factors include single gene defects, chromosomal abnormalities, environmental factors, then some gender differences in some types of congenital heart diseases. Next slide. So in about 85 to 90% of children, there is no identifiable cause. But multiple factors contribute to cause risk for congenital heart disease. And some of these factors include maternal medications such as anticonvulsants, lithium, then diabetes, then maternal lupus, and rubella. Next slide. Then when there is a positive family history of congenital heart disease, there's an increased risk of other children getting congenital heart disease. Then chromosomal abnormalities such as Down syndrome, trisomy 18, trisomy 13, Turner syndrome, and Cri-du-Chat syndrome. All these are risk factors for congenital heart disease. Next slide. So this is the relative frequencies. Like we all know, PSD, ventricular septal defect, is the commonest congenital heart disease, followed by atrial septal defect, then with relative frequencies of about 6 to 8% of all congenital heart disease. Then tetralogy of Fallot, about 5 to 7. Then other forms are relatively rare. Next slide. Next slide. So, how do we evaluate children with congenital heart disease? Basically, we have two types of congenital heart disease based on the presence of cyanosis. We have the acyanotic and the cyanotic. We all know what cyanosis is. Cyanosis is presence of bluish or darkish discoloration of the lips and the mucous membrane, right? So we basically divide congenital heart disease into two. We have the cyanotic and the acyanotic congenital heart disease. Then, based on chest X-ray, we can see there is those that have normal pulmonary blood flow, and we have some that have increased pulmonary blood flow and some that have reduced pulmonary blood flow. Then based on ECG, we have those that will have right axis deviation. That means they will present with right axis right ventricular hypertrophy, and some with left axis deviation presenting with left ventricular hypertrophy. Then some with biventricular hypertrophy, right? Then the final diagnosis is based on echocardiography. Next slide. So acyanotic congenital heart disease, basically what you have is left to right shunt. So we all know the left side carries oxygenated blood and the right side carries deoxygenated blood. So if there is shunting of oxygenated from the left side to the right side, what happens is there will be increased blood flow to the lungs. And as such, most at times, they will not present with cyanosis, but they can present with increased pulmonary blood flow, leading to right ventricular enlargement and heart failure. Is that clear? So the commonest is the atrial septal defects, and we have basically three sites of atrial septal defect. We have those that will occur at the ostium as the fossa ovalis, it is called ostium secundum type. Then we have the ostium primum and the sinus venosus. This is the three forms of atrial septal defects. And the basic pathophysiology is left to right shunt. Next slide. Next slide. So we can see, no, previous slide. So we can see the B part, there is left to right. That means oxygenated blood is going back into the right atrium and is further pushed for re-oxygenation back to the lungs. Next slide. So most are asymptomatic, but they may present with wide and fixed splitting of the second heart sounds, right? But most ASDs are asymptomatic. Next slide. Sorry, I have a little cold, so my voice is somehow. You have to make do with that. So diagnosis is basically using echocardiography, or it may be done clinically. Then when you do chest x-ray, you may see right ventricular hypertrophy. Then you may also see right axis deviation. Then the prognosis is usually very good because most at times they don't present with any symptoms. So the prognosis is very good, but occasionally they may present with pulmonary hypertension and Essenmenger syndrome. Treatment is mainly surgical for all that are symptomatic. Next slide. So this is what we are talking about. This is atrial septal defect. We can see oxygenated blood getting into the right side of the atrium, now into the ventricles, and it's going back for reoxygenation. So we can see it is purple. Next slide. Next slide. Next slide. Now the ventricular septal defect is actually an opening in the ventricular septum. And this also similar allows oxygenated blood get into the left ventricle through the opening, right? And it's the most common cardiac malformation. And the majority of the defects will occur at the membranous portion, because we have two portions of the ventricular wall. We have the muscular and the membranous. So majority will occur at the membranous. Then some will also occur at the muscular. It's also called the Swiss cheese defect. The basic pathophysiology is left to right shunt. Left to right shunt. So there is more blood going into the lungs for reoxygenation, right? So the basic problem is left to right shunt. Next slide. So we can see left to right. But with time, because of increased work of the left ventricle becomes hypertrophied. So there will be what is called reversal of shunt. That means instead of the blood to move from left to right, there will be reversal because the right ventricle has become overworked, so it becomes hypertrophied. So that means it will be pushing blood to the other side. So that is what is called Essenmenger syndrome. Is that clear? So this is what the arrow is showing. So that is what is called Essenmenger syndrome. So anytime you hear Essenmenger syndrome, it means a reversal of shunt. From the left to right, it becomes right to left. And that is why those children with acyanotic congenital heart disease will begin to present with cyanosis, because right to left shunt means deoxygenated blood getting into the systemic circulation. Next slide. So diagnosis can be clinical. The chest x-ray will show cardiomegaly, obviously, right? But the basic symptoms are symptoms of heart failure. You have fatigue, sweating, tachycardia, tachypnea, then poor weight gain and recurrent chest infection. Then diagnosis can be clinical. Using chest X-ray, we show cardiomegaly. ECG will also show right axis deviation because the right side is working more than necessary. Then echo is definitive. Then the prognosis, about 50% of small VSDs will close on their own. Then those with large defect, they have to be closed. Next slide. So management is treatment of heart failure. So you have to give diuretics, you have to give digoxin. Then surgical repair is the definitive. Complications include infective endocarditis, recurrent chest infection, heart failure, and other complications. Next slide. So this is just what we talked about, ventricular septal defect. You can see a defect in the ventricular wall, and oxygenated blood is coming into the right ventricle, and that is pumped into the lungs for reoxygenation. Next slide. So we'll just talk about patent ductus arteriosus. And the patent ductus arteriosus, in many children, nobody knows why it remains patent. It is relatively common in premature infants. But the pathophysiology is similar to what you find in VSD, only that the shunt occurs outside the heart, so along the aorta. So blood is shunted from the aorta into the pulmonary arteries directly. So there is increased blood that is going into the lungs for reoxygenation. Is that clear? So the pathophysiology is increased pulmonary blood flow. So the presentation is similar. They will present with heart features of heart failure, recurrent chest infection, poor weight gain, and all those things. Next slide. So like I said, presentation is similar. Poor weight gain, fatigue, sweating. But in addition, they have increased systolic blood pressure, they have pulses. Diagnosis can also be clinical. Then chest X-ray will still show you right ventricular hypertrophy. Then ECG will also show right axis deviation, and echocardiography is definitive. Next slide. So medical management, you can use some drugs to close the PDA. So some of the drugs used include indomethacin, because all prostaglandin inhibitors can help in closure of the ducts. So we use prostaglandin as a medical management. Then the normal management of heart failure, which include digoxin and diuretics, are also important in the treatment. Next slide. So this is what the duct is showing you. You can see the ascending aorta. There's shunting of blood from the ascending aorta into the pulmonary arteries, and this blood is taken back for reoxygenation. So there will be congestion of the lungs because there will be increased blood flow into the lungs. Next slide. Next slide. We'll skip. We'll just take the common congenital heart disease. So next slide. Next slide. Next. Next. I think you can read the others. We'll just take the common ones. So in coarctation of the aorta, it's actually narrowing along the aorta. And this narrowing can occur anywhere, but it's commonly seen after the aortic arch. And the basic effect is that there will be reduced blood flow to the systemic circulation, right? Because there is obstruction. And with that, the right side, the left side of the heart will be made to work harder to increase blood flow into the systemic circulation. So there is a risk of left ventricular heart failure. Is that clear? And they can also lead to hypertension in the upper limbs and hypotension in the lower limbs. So one of the causes of hypertension in children is coarctation of the aorta, right? Next slide. So you can see the site of coarctation, right? Just after the arch, there is coarctation. Next slide. So you can find differential blood pressure. In the upper limbs, there will be high blood pressure. In the lower limbs, there will be low blood pressure. So it's only coarctation that will give differential hypertension. Hypertension in the upper limb, hypertension in the lower limbs. Next slide. Next slide. Yeah, so sign and symptoms. No, previously, sign and symptoms, basically, they present with irritability. They present with excessive sweating. They also present with poor weight gain. Then the legs usually are cold with absent blood pressure, absent pulses in the lower limb. Then the blood pressure in the lower limbs may also be absent, right? Then clinical manifestation, they can present with hypertension, with differential cyanosis. So the upper limbs will be pink and the lower limbs will have cyanosis. Then classically, you find what is called radiofemoral delay. That means you pick the pulses in the radial limbs before you pick it in the femoral pulses. Next slide. Then diagnosis may be clinical, and you can find chest X-ray will show left ventricular hypertrophy. Then echocardiography is the definitive management. Prognosis, usually they die by around 20 to 40 years without treatment, and complications, you can have stroke, infective endocarditis, and aneurysm. Management includes treatment of heart failure, treatment of use of prostaglandins, and surgical correction. Next slide. So I talked about Essemenga syndrome. Is there any question on Essemenga syndrome? Any question? Or any questions so far on what we have discussed? Any questions? Questions?
So no, we don't have questions, sir.
So, are we clear? Are we understanding? Are we following? Huh? So
yes, sir, we are following you. Not that clear.
Next slide. Yeah, so now we are going to talk about cyanotic congenital heart disease, and with basic emphasis on tetralogy of Fallot. Tetralogy of Fallot is a congenital cyanotic heart disease. They are also divided into those that will cause increased pulmonary blood flow and those that will cause reduced pulmonary blood flow. So all congenital cyanotic heart disease, or all congenital heart disease that will cause increased pulmonary blood flow, basically they will present with heart failure. We clear, this is a general statement. All congenital heart disease that will present with increased pulmonary blood flow will present with heart failure, whereas all congenital heart disease that will present with reduced pulmonary blood flow will not present with heart failure. So that is why tetralogy of Fallot is associated with reduced pulmonary blood flow, and it does not cause heart failure. Are we clear? It has four basic characteristics. The first is right ventricular outflow tract obstruction. That's the basic pathology. Then they have ventricular septal defect. Then they have transposition of the aorta and right ventricular hypertrophy. So this is the basic problem in tetralogy of Fallot. So the basic problem is reduced pulmonary blood flow. Next slide. So the basic sign and symptom is cyanosis. The basic presentation is cyanosis, right? And some of these cyanosis may be noticed when there is increased activity. Then they may present with murmurs, may present with tachycardia, irritability, and finger clubbing, right? Next slide. Like we said, they also have classically squatting. So the children will be squatting when they are walking. They squat for some time before they continue. It's classical of TOF. Anytime the mother tells you there's history of cyanosis, finger clubbing, and the child when he's walking, he squats for a while before he continues. It's classical of tetralogy of Fallot. Diagnosis: chest X-ray will classically show a boot-shaped heart. Please, let's get this. It will show a boot-shaped heart. It's a common question. Then echo will show the definitive diagnosis. Complications include cerebral thrombosis, brain abscess, infective endocarditis, hypercyanotic spells. Next slide. So you can see this is a child with hypercyanotic spells. It's just a child with worsening cyanosis. You can see suddenly the child becomes extremely cyanosed. You can see the pink extremities. These extremities are extremely cyanosed, which is called TET spells. Next slide. And the management, you can do medical and surgical. Medical management is use of prostaglandins, use of propranolol, and definitive treatment is plaloxacin procedure. Next slide. So this is just showing us TOF, right? Hello. Anybody has question? Question. So we can see tetralogy of Fallot. There is right ventricular outflow tract obstruction, right? Then there is transposition of the aorta. You can see the aorta is like on the ventricular septum.
Yeah. That's
If you have any question, you can stop.
really understand it. Like, it goes through MCQs in is it a quick guarantee chance that we're going to pass, like if you only focus on what he sends us, you get?
Fatima, you are interrupting us. It's Fatima Makinta. So can we proceed? So next slide. Next slide. Next slide. Next slide. Next slide. Like I said, we are going to talk about only the common ones. Next slide. Next slide. Yeah, so there's those with increased pulmonary blood flow, right? And the common is the transposition of the great arteries. So in transposition of the great arteries, what happened is the aorta arises from the right ventricle. Then the pulmonary arteries will arise from the left ventricle. That means the systemic circulation gets deoxygenated blood and the lungs get oxygenated blood for reoxygenation. Is that clear? So the only way the systemic circulation will get some oxygen is when there is a shunt, when there is a VSD. So there is usually a VSD where there is mixing of blood, and that allows the systemic circulation to get some blood. Is that clear? So that's the basic pathology. Next slide. So we can see the aorta is arising from the right ventricle, and the pulmonary arteries are arising from the left ventricle. That means the blood, oxygenated blood, is taken back to the lungs for reoxygenation, and deoxygenated blood is taken back to systemic circulation. Next slide. So usually they present with cyanosis immediately after delivery. Then they have difficulty with breathing. Then they may present with congested heart failure. Next slide. Then typically chest X-ray will show what is called egg on side appearance. You see the heart will appear like an egg sitting on the side. So it is called an egg. Of transmission of the great arteries. Any question? Any questions so far? Next slide. Next slide. So this is after arterial switch. Treatment is by arterial switch surgeries, right? You can see transposition of the great arteries. The right atrium, the aorta is arising from the right ventricle, and the pulmonary arteries arising from the left ventricle. And treatment is by arterial switch procedure. You just switch the aorta back to the left and the pulmonary artery to the right. Next slide. Next slide. So in truncus arteriosus, what you have is next slide. Next slide. Next slide. Yeah, so in truncus arteriosus, what you have is a single vessel arising from both ventricles, and it subsequently divides into the aorta and the pulmonary artery. So there is total mixing of blood. So the whole blood is completely mixed between deoxygenated and oxygenated blood, and half divides into the aorta, which goes into the systemic circulation, and half goes into the lungs for the oxygen. So that's what truncus arteriosus is all about. Next slide. And treatment is by surgical correction, and presentation is similar. They present with cyanosis, fatigue, sweating, difficulty with breathing, and the rest. Surgical correction is usually immediately after delivery and is done to separate the aorta from the pulmonary vessels. Next slide. Next slide. So we can see the trunk. Previous slide. Previous. So we can see it's a single trunk arising, that is the truncus, and subsequently divides into the aorta and the pulmonary artery. So you can see the whole blood is pink because there is total mixing of the blood in the trunk. So that means systemic circulation is still getting a mixed blood, and the pulmonary vessels are still getting a mixed blood. Next slide. Next slide. Next slide. Next slide. Yeah, in single ventricle, what happens is there's so similar to that, there's complete mixing of the blood, right? There's complete mixing, and it's just similar to what you see in truncus arteriosus. Next slide. Next slide. Next slide. So any questions? So basically, the aim of this is just an overview. So have an overview on ASD, VSD, PDA, and TOF. The remaining, you may not bother so much on them, but it's just an overview. And the slides are very friendly, very easy to use, and I'm sure you use them, you'll be able to read and understand. So any questions? Please, let's all unmute and ask questions, please. This is a very, very important presentation. And that's why I like it when it is started done early before we get tired. So let's all unmute and ask questions. Questions? Aisha SM. Aisha Nguku. Aminu. Let's all unmute and ask questions. Questions?
I have a question, please.
Yes,
It's on Essemenger syndrome.
Yes.
Is it a complication or does it come on its own? What
It's
is
a
it about?
complication. Like I said,
Complication of what?
let me just explain it again. You see, Those that have left to right shunt, what it means is blood that is supposed to go to systemic circulation is shunted back to the lungs for reoxygenation. So the normal blood that is supposed to get to the lungs is increased. Is that clear? So the right side of the heart will have more work to do because it's pushing more blood into the lungs. So with time, it becomes hypertrophied. With that hypertrophy, there will be reversal of that shunt. Instead of the shunt to go left to right, it goes right to left. So that is what SM Benga is all about. So it's a long-term complication of left to right shunt.
Okay, thank you.
Yeah. Any other question? Questions? Questions? There are no questions? We all understood everything? Okay. So, I don't know. We are supposed to have 3 lectures today. I don't know. I have this serious cold. I don't know if we can proceed. Maybe if we can leave it till tomorrow and we'll take the lectures tomorrow. I don't know if it's okay by you guys. I have this serious cold. I'm having difficulty talking.
It's okay, sir.
Yeah, I don't know, my voice is cracked. I have difficulty talking well. So I don't know if it's okay by you guys, if you can shift it till tomorrow.
No problem, sir. It's okay. Sorry.
No problem.
Is 11 still okay by you guys?
Yes, sir. Yes, it's okay.
It's okay?
Yes, sir.
Yeah, so I'm sorry, the network has been bad, and also with my voice, it's not too good.
No problem,
Maybe
sir. It's okay.
I hope by tomorrow I will feel much better, and we'll have a better outcome. So thank
Okay,
you
sir.
for your time.
Much. Thank you.